Which of the following ossification centers is first to appear? A. Medial cuneiform. B. Intermediate cuneiform. C. Lateral cuneiform. D. Cuboid. E. Navicular. And the answer is D. Cuboid. What's the reason for this? Let's find out. Primary ossification centers present at birth. Visible on X-ray from birth, the calcaneus at 6 months in utero, the thallus at 7 months in utero, the cuboid the 9 months in utero, metatarsals 9 weeks in utero, the phalanges 3 to 10 months, started from proximal to distal. This picture illustrates the ossification center of the foot, already highlighted in the green for our answer. Primary ossification centers developing after birth become visible on X-ray from: for lateral cuneiform at first year, for medial cuneiform at third year, intermediate cuneiform and navicular at fourth year. So it started off from lateral to medial. Secondary ossification centers. At the age of 3 years, secondary ossification centers of the navicular, metatarsals, and phalanges should all be present. The last secondary ossification center to develop is the calcaneum, appearing at 5 years. Okay, thank you. A 5-year-old child has Perthe disease of 6-month duration. Taking the natural history of the disease into account, he is likely to have at the age of 30 years A. Coxa plana, B. Secondary osteoarthritis, C. Shortening of the lower limb, D. Trendelenburg gait, E. Fairly functioning spherical head of femur. And the answer is E. Fairly functioning spherical head of femur. Now let's get to know the reason for this answer. Study by Perthe et al. 2010 for the natural history of Perthe disease. The 5-year radiographic results were strongly dependent on 4 risk factors. 1. Age 6 years or more at diagnosis. 2. Total femoral head necrosis. 3. Height of the lateral pillar of the epiphysis less than 50% of normal height. And 4. Femoral head cover less than 80%. As the number of risk factors increase from 0 to 4, the proportion of patients with good radiographic 5-year outcome decreased from 79% to 0%, and the proportion with poor outcome increased from 3% to 91%. Interpretation of study by Perthe shows that most children under 6 years of age do not need any special treatment. In older children, no special treatment is indicated if the whole femoral head is not necrotic and the femoral head cover is more than 80%. In the most severe forms of the disease, there is more than 2 risk factors. Surgical containment treatment seems advisable. Study by Stulberg et al. 1981. He concluded that the clinical and radiographic cause of an involved hip subsequent to childhood was related to the type of congruency that existed between the femoral head and acetabulum. 3 types congruency were recognized. Number 1, the spherical congruency in class 1 and 2 hips. The hip in this category, arthritis does not develop. Number 2, aspherical congruency, class 3 and 4 hips. Mild to moderate arthritis develops in late adulthood in this hip. Number 3, aspherical incongruency in class 5 hips, whereby severe arthritis develops before the age of 50 years old. Okay then, thank you. A 75-year-old male was admitted for elective total hip arthroplasty. During his pre-operative assessment, he is on furosemide for antihypertensive medication. Where is the site of action of this diuretic? A. Distal convoluted tubule, B. Proximal convoluted tubule, C. Descending lip of the loop of Henle, D. Ascending loop of the loop of Henle, E. Collecting ducts. And the answer is ascending lip of the loop of Henle, D. This picture shows an action of loop diuretics. Example of loop diuretics include furosemide, torsemide, bumetanide, etraclinic acid. That's all. Thank you.
A 50-year-old male presents with progressive mild to low back pain increasing in severity for the past 1 month. He is 8 months post T6 to T11 fusion for a T9 burst fracture. Radiograph shows a solid fusion with well-placed instrumentation. There is collapse of his T12 vertebral body with increased radio density that was not present at his last post-operative visit. His most likely diagnosis is A. Old T12 compression fracture, B. Kummel disease, C. Schumann disease, D. Tuberculosis, E. T12 burst fracture. And the answer is B. Kummel disease. Now let's get to know about this disease. Kummel disease, KD. It is a rare form of delayed post-traumatic osteonecrosis, typically precipitated by mild or minor trauma to the lower thoracic and lumbar spine. A German surgeon, Hermann Kummel, 1895, hypothesized that the nutrition of the affected vertebral bodies is injured, leading to delayed collapse of the vertebral bodies. Pathophysiology of Kummel disease suggested the initial trigger of trivial trauma results in subtle disruption of the bony spongiosa with microhemorrhages. Subsequent vascular insufficiency result in impaired healing and delayed osteonecrosis. The etiological contribution of vascular insufficiency is supported by finding a delayed vertebral body collapse with normal appearance on routine CT imaging but with an abnormal bone scan. Kummel disease or avascular necrosis of the vertebral body represent a failure of the fracture healing process after a minor traumatic injury. Kummel disease commonly occur in the middle-aged to elderly men. The risk factors include chronic steroid use, osteoporosis, alcoholism, and radiation therapy. Repetitive spinal loading in hyperflexion as a triggering factor for a young patient. Diagnosis is usually requires exclusion of other causes of vertebral body collapse and osteonecrosis. The example include neoplasm, infection, especially tuberculosis, metabolic disorders, radiation, osteoporosis. Radiographic examination shows an intravertebral vacuum cleft on radiograph, referred to as Kummel sign. It is highly suggestive of ischemic necrosis and corresponds to the double line sign on MRI. The radiolucent linear or semilunar shadow represent a gas, principally nitrogen, in the fracture line of the vertebral body. The gas presumably originates from the surrounding tissues. This picture illustrates a lateral X-ray view that shows a vacuum cleft sign or Kummel sign. One of the most characteristic features of Kummel disease is normal radiological study immediately after trauma and subsequent development of rarefaction and loss of bone tissue, leading to collapse of the vertebral body after a delay of weeks or months. Delayed compression deformity of the affected vertebral body and exaggerated thoracic kyphosis can be demonstrated on plain radiography, CT, or MRI. Vertebral osteonecrosis with an intravertebral vacuum cleft is best shown on CT. CT scan shows a compression deformities with sclerosis of the end plates and virtually pathognomonic foci of air within the vertebral body. This CT scan coronal and sagittal view shows foci of air within the vertebral body. MRI demonstrates a double line sign, where a linear region of low intensity represents the vacuum cleft surrounded by elevated T2 or flare, fluid attenuated inversion recovery, signal of the fracture deformity or intravertebral fluid. This picture shows an MRI sagittal view that shows a Kummel disease in T2 weighted images. A shows a fluid collection. B shows a gas containing space. Okay, thank you.